Our next panel is to talk about some state-level programs and policies, because in many ways, as we know, the states are supposed to be the experimental entities. That was what was envisioned by our nation's founders and under the Constitution, and therefore it's appropriate that we not just learn from other countries, but we learn from the states, which are the models of experimentation. And we've got three very capable and distinguished professionals with us this afternoon, representing two of the more progressive states and then a national perspective. First, we're going to have Dr. Susan Toll, who is Director of Center for Ethics in Healthcare for Oregon Health and Science University. Then after Susan, I'll go ahead and introduce the other two speakers. Myra Christopher, Kathleen M. Foley Chair for Pain and Palliative Care, Center for Practical Bioethics, and then Peg Metzger, healthcare consultant from Wellesley, Massachusetts. We're really looking forward to hearing what y'all have to say, because you're really on the front lines in many ways. So please, Susan.
It's wonderful to be here. It's great to see so many old friends. Today, I want to share with you Oregon's path to eliciting, recording, and respecting wishes across settings of care. And I can take coaching from where I need to. I think it's helpful to know the financial backing of our Center for Ethics in Healthcare, because I think it helps you understand perspectives that we might come from. We are supported heavily by private philanthropy, and in the Ethics Center's almost 25 years, we have not accepted gifts from the healthcare industry. In the next 15 minutes, I'd like to cover 7 areas fairly quickly. One of them is the problem. Why did we create the Physician Orders for Life-Sustaining Treatment Program? And I think it's best summarized by a separate little handout you got, a story of Max. But a human story, a real story, about someone who didn't want medical treatments that they ultimately received because orders weren't available when they were needed. I'd like to share the early history of the POLST paradigm, how it was developed, structured, and then how statewide dissemination occurred. I'd like to honor the fact that the Greenwald Foundation provided the initial support for what has become the National POLST Paradigm. The statewide dissemination was made possible by a grant from the Robert Wood Johnson Foundation in 1998. I'd like to talk about the message that we give those that we train in our state and why that message is important to promoting trust. I'd like to share how electronic registries can make a real difference in being able to locate things quickly, and how they might work in a relatively economical way to create almost a registry system in an integrated health system. I want to share the Oregon POLST Registry, which has been in operation for 3 years, and how that is working, and being able to actually serve emergency medical personnel in the field. And then I'll show one map of the rest of the country. So most of our time will be spent on Oregon, its roots, because we have many leaders in individual states, including some of my colleagues on the panel, who could really speak to, in great detail, the wonderful things that are happening in their own states. In 1990, ethics leaders in Oregon came together for our annual statewide ethics conference, and every person began to say, we have people admitted to our hospitals who have treatments they don't want because they had conversations somewhere that aren't getting where they need to be, and we're intubating people, and it happens over and over and over again. We built a statewide coalition to try to deal with this problem, and in doing so, we made sure that stakeholders were all represented. We made sure that we had people from long-term care, from hospice, from emergency medicine, from hospital associations, nursing associations, disabilities community, aging services. We had about 40 people on the coalition. And to this day, they help us reach out with statewide education. That is who have really made things happen. They help design and continue to meet regularly and make the revisions in the POLST form that I've shared with each of you today. It took us 4 years before we had the ability to do pilot testing. This is the first pilot study. It involved study in several communities, 8 nursing homes, admitting each to a different health system, following prospectively for a year people who had marked on the POLST form, do not resuscitate, and in Section B, comfort measures only. They didn't want to go back to the hospital, and we followed what happened to them. We found that 5% died in an acute care hospital, and some of those should have. They fell, they had a hip fracture, their comfort couldn't be managed on site. The number shouldn't be 0. And that not a single one got ICU care, ventilator support, intubation. With that, we were ready to begin dissemination. To do the dissemination, our coalition worked very hard with all of their constituents. EMS had mandatory education each year for emergency medical personnel. Long-term care facilities developed train-the-trainer models for each facility. Hospice programs reached out to every single hospice program. We then held and hosted, with the Robert Wood Johnson grant, prior to the Community State Partners Project, these regional meetings where the different agencies and organizations that were transferring and admitting to each other could talk. We also worked on all kinds of other aspects of palliative care at the same time. POLST was not freestanding. In the end, we had about 600 what we called change agents in action, somebody in each little hospice program who went back to their program, showed slide sets, taught others. But it's this grassroots effort that reached out into a state that has large rural areas as well. We taught them to think about their message. And I think this is a good time for me to also declare that, as all of you know, I'm from Oregon. Does that mean anything to you? Well, it means a lot to a lot of people. And so one of the things we needed to clarify was, what is the POLST program, and what is what some of my colleagues in the rest of the country call physician-assisted suicide, or the Oregon Death with Dignity Act. And the rest of my talk will be focused on helping us understand the clear distinction between the two, and then focusing time where the ratio of care seems to best fit. The Oregon Death with Dignity Act allows physicians to prescribe a lethal prescription to persons who are terminally ill, and the patients self-ingest that prescription. That is used 15 years into implementation in Oregon by 2 people in 1,000 who die each year. The other 998 often have very strong feelings about the level of palliative care they receive, choices about whether to have or to limit treatment, and the POLST program serves them very well. Most people end up setting some limits by the time they die, making a decision not to restart something. Every hospital, health system, nursing home, hospice program uses the POLST program in my state, including all of the Catholic facilities in my state. They use it for residents who are appropriate. Obviously, some people are not a POLST appropriate candidate, and we'll talk about that in just a moment. None of the Catholic facilities utilize the Death with Dignity Act. So I'm going to focus my remarks in the formal part of my talk on what I call the 998, the vast majority of Oregonians who want some treatments and not others often as their disease progresses. One of the biggest challenges is, since POLST has become so widely utilized in my state, a little is good, a lot is better, and some people are being offered POLST forms who are too healthy, in my opinion, and should have an advance directive. So we encourage people to say POLST is designed to honor the freedom of persons with advanced illness or frailty to have or to limit treatment across settings of care. POLST is entirely voluntary. I don't make any more money if you fill out a POLST form and you want everything, or you want some limits, or you want comfort measures only. No one has to complete a POLST form. You can have or limit treatments as you wish. You can change it at any time, and later we'll talk about how often POLST forms are changed. Comfort measures are always provided. That's not optional. And we saw in that early nursing home study, people were admitted to the hospital with a hip fracture, and sometimes they died there. And when we added the registry, you don't have to be in it if you don't want to. We wondered how well we were doing with our dissemination. So Dr. Virginia Tilden did a study of 6% sample of Oregon death certificates in 2002, calling the next of kin. This was published in JAGS, and asked a lot of questions about end-of-life care and how things were going in Oregon and how well wishes were being respected. But one of the questions was, did your loved one have a written document, an advance directive, or a POLST form at the time of death? And 78% said yes. Half of those had completed the document in the final year of life. So I am certainly not here to tell you that a majority of Oregonians have a written document. A majority of terminally ill Oregonians have a written document. What does the rest of the country think about the aggressiveness of care that is provided in Oregon? Included in your materials should have been this information from the Dartmouth Atlas, and page 6 of it has just been passed out. A medical student at Dartmouth used the Dartmouth Atlas to look at where medical students from Dartmouth do residencies when they go to prestigious academic medical centers, and then compared all the demographics about aggressiveness of treatment in those academic centers. And on the slide, I've put the top 2 and the bottom 2 as far as aggressiveness of treatment. There are profound differences in this country. This data is from the Dartmouth Atlas, looking at deaths in 2003 to 2007. And remembering that the Dartmouth Atlas is for people over age 65 and uses fee-for-service data. So you can see that there is a twofold difference in most of the categories on aggressiveness of treatment. More than that related to physician visits, but twice as much hospice, half as much death in the ICU. Now, Joan Tenno and colleagues would clearly tell us that some of this is because of Oregon's very favorable demographics, that there are lower bed availability per thousand and higher ratio of primary care. But we were interested beyond that and the favorable demographics, what made Oregon appear so less aggressive in this list, and to what role might POLST be playing any role? Susan Hickman did a study of 90 nursing homes in 3 states, looking at matching those with and without POLST forms at a time when POLST was not being used as a process of rollout, and some facilities were using it, some not. She looked at a 60-day period of time and looked at the aggressiveness of treatment. For those with comfort measures only, Section B of the POLST form marked comfort measures. There was a 67% reduction in unwanted life-sustaining treatments, primarily hospitalizations and emergency room visits, compared to those who wanted full treatment, and those who wanted full treatment were statistically the same as those with traditional practices, meaning no POLST form. The suggestion is that POLST is associated with aggressiveness of treatment and that the orders make a difference. If that's the case, then let's be able to find them, and find them fast. 6 years ago, the Oregon Health and Science University moved to an electronic record system. And in the process of the move, they put POLST and Advance Directive separately on the patient header. And if you had a form, they put it in the color blue, so it stood out. If you click on that, then you call up the history of documents on the patient. If you click on one of the documents, you see it immediately. Within seconds of a patient arriving in the emergency room, we're able to tell whether or not they had a POLST form and what the orders say. Others have found this extremely useful. This is a California health system, and they have followed a similar model of putting the orders separately. I would encourage not putting POLST and Advance Directive in the same bucket, but keeping the orders separately. You need to find them so quickly. And a POLST yes means if you go looking, you're going to find something. This is the region-wide Providence system, also showing the same POLST. POLST goes by different names and has different colors, and they have chosen a different color but a similar model. This is the first-year data from the Oregon POLST Registry, the year 2010. 25,000 people submitted POLST forms to the Oregon Registry in the first year of operation. The majority are elderly. 1/4 want CPR. 3/4 do not. Of those who do not want CPR, half want to return to the hospital and half don't. If you have not asked the questions in Section B about comfort measures, if you want to go back to the hospital, do you want ICU care? I don't see how you will know whether the individual wants them or not. This is current data about the Oregon POLST Registry from last month. Registrants are individuals. Many of these people have a second or sometimes third POLST form. To put Oregon in perspective, we're 1% of the national population and 32,000 people die a year. Many of these registrants are deceased. We have had over 2,000 phone calls in a time of crisis to the registry system, including being able to respond by radio to EMS in the field. We are loading 3,500 POLST forms a month, and about 500 of these are revisions. POLST is a process, not an event. And of course, it's only as good as the conversation. I'd like to highlight a few resources for you. One is Amy Vandenbroek, at the far side of the room. Wave your hand, Amy. She's the executive director of the National POLST Paradigm Task Force. If you can't find anything I've referred to, call Amy. Pathways to Building a POLST Program was written by AARP, Naomi Karp and Charlie Sabatino, and is an excellent map of pathways to implementation if you have different kind of legal barriers to face. Another document is the pathway of registry development. This is also available online, but it's how different states have followed a pathway to create any kind of electronic POLST registry system. Another document is all of the instruments that have been done for any published study about the POLST program have been collected by Eric Fromey in the document that was made available this February. It's easily searchable online. It suggests a tremendous amount of sharing that happens within the POLST program, and that sharing has really helped all of us advance. The document you have in your hand is the 8th version of the Oregon POLST form. It changes over time. Technologies change. When we wrote the first POLST form, there was no CPAP, BiPAP. So we change with technology, we change with what we learn. The National POLST website is listed here, as well as the Oregon website and a website just about the registry. I encourage the committee to think about having others who have had very successful programs in their states express those programs. You have one as a member of your committee, Pat Bomba. She is one of 4 most advanced states in the country. New York, California, West Virginia, and Oregon are formally mentoring other states in the rollout of POLST. And I'm happy to answer questions during the panel, and thank you again for coming.
Well, I will say up front, I do not use slides, but I do have copies of my outline if any of you would like to have them this afternoon. About 35 years ago, at her wish, my mother died in our home after a 2-year really fierce battle with a rare cancer. We were living in a community that at that point did not have hospice. It had not yet emerged. And following her death, I was standing at her graveside and made a promise to myself that I would spend the rest of the days of my life working to see that other families could possibly have the same kind of positive experience that our family had had, but that it would not have to be quite so hard for them. I never imagined that that journey would bring me here to be with you today. I'm very grateful for that opportunity. So I want to share a very strong bias that I hold, and I think it is defensible, that healthcare is fundamentally a local enterprise. It is very rare for any person to travel more than 150 miles in their lifetime to receive health care. And as we all know, and as Dave alluded in his welcome back this afternoon, health care is regulated at the state level. So I think for us to imagine completely transforming end-of-life care in our country, which is in progress, it will require efforts at local, state, and national levels, and it will require us thinking about the interface between those and how we can align them so that we get as much synergy as possible. I had the privilege of running a national program for the Robert Wood Johnson Foundation called Community State Partnerships to Improve End-of-Life Care. I'm not here to be nostalgic as I talk about this, but I am going to talk about it. But I do strongly believe that past is prologue. This is was an $11.25 million grant award program, and it was designed specifically to support and foster the creation of statewide coalitions that would work on improving end-of-life care. And it was housed at the organization that I have been associated with now for 30 years. It is now called the Center for Practical Bioethics. At that point, it was known as Midwest Bioethics Center. The goals of community state partnership were very explicit. They were to remove barriers to good end-of-life care, develop policies and implement practices to promote excellence, create public understanding about end-of-life choices, and to monitor the impact of the efforts of the state coalitions. Now, we did propose things that we were interested in, and we hope to see greater demand for high-quality end-of-life care, increased capacity, increased workforce capacity, delivery capacity, broad public policy changes that we knew were necessary. However, we did allow the states to really set their own course. One of the things that we learned was that there was very little knowledge about, very little data about what was really happening at the state level. We made about 24 grants, and we had about 6 affiliated programs that we provided support and technical assistance to, as well as grants. Many of you in this room were involved in that initiative. I said it felt like a high school reunion to me this morning when we came in. Now, what did happen was that some very common strategies emerged. There was not as much difference in what the states chose to work on as we had at one point thought that there might be. Everybody knew that we still need to, revise the curricula that our healthcare professionals are educated with. Not just those in training, but also the practicing clinician needed additional information. At this point, it was so unusual when healthcare professionals even knew what the word palliative care meant. People mispronounced it, they stumbled around it. We knew we needed to have changes not just at state policy levels, but also in institutional policies. And I think sometimes to the chagrin of the Robert Wood Johnson Foundation, our view of what policy is was very broad and inclusive. We wanted very much to see clergy and faith communities involved, and frankly, from my point of view, they can be enormously helpful, and they can also be enormously difficult. So I think it's a double-edged coin. We also wanted to see new reimbursement models. So the challenges that the grantees and those affiliated programs reported back to us is that they had very limited infrastructure. These were volunteer coalitions who came together. So they all had day jobs. Now, we did support a little bit of time for a PI and a little bit of support for a project manager. They also reported back that there was enormous resistance to change. And I don't think we're quite over that hump yet, but I think it is dramatically different now than it was when this program started in 1999. And it was also the case that because, as people said then, healthcare was in so much turmoil and chaos that there was just enormous turnover. That's all gotten settled down, so it's not a problem anymore. But, at that point, someone who was, the volunteer coordinator for the local hospice or the local hospital might change jobs 2 or 3 times during the course of our grant period. Melanie Merriman, who many of you know, actually did our evaluation at the end of our program, and I am, if you will bear with me, I want to read to you one paragraph from that multi-page, I think almost 100-page report. And if anyone is interested in that, I, again, would be happy to share with you. It is clear that CSP projects are becoming powerful agents for change. They've increased the capacity to deliver quality health care through education of healthcare professionals, changes in medical school curricula, and process improvement in hospitals and nursing homes. They have increased access through legislative changes that require Medicaid and private insurers to pay for hospice and other end-of-life care services. They've increased the demand on professionals for better end-of-life care through work with licensing boards to develop new and revised standards for care of the dying, and through legislative changes that require professionals to obtain training in end-of-life care and that establish task forces to study end-of-life care within the state. Largely through the work of CSPs, 100 separate legislative acts were judged to enable better end-of-life care were passed in the 23 states funded between 1999 and 2000. So within 2 years, we saw a really pretty dramatic change in policy at the state level. Now, unfortunately, Robert Wood Johnson funding ended for this program in 2003. And we tried very hard to find other foundations to support the coalitions, to continue to support their work. But we were not successful with that. And I think there were 2 reasons for that. The resources needed to support a project of this size and scope when you're working with half of the states were significant. And in addition, which I found a little bit odd, the Robert Wood Johnson Foundation brand is golden, unless you're with some other foundation, and they don't want to pick up RWJ leftover work. So in 2002, kind of wrapping up this initiative, we actually interviewed 35 leaders from around the country and said, okay, tell us what you think needs to happen in the future. You know, let's be a little bit future-oriented here. And we did, I believe in your reading packet, you did receive a copy of the last issue of state initiatives in end-of-life care. Some of the things that were reported in that were very specific about policy, federal and state. At the federal level, they felt that standards for palliative care needed to be adopted and mandated. Comprehensive palliative care faculty training programs with special attention to issues related to diversity and discrimination needed to be addressed. We needed to provide reimbursement, appropriate, adequate reimbursement for palliative care, and that we needed to get rid of the 6-month rule in hospice. They also suggested that there should be a palliative care NIH institute created at NIH, that there needed to be balance restored in pain with regard to prescription medications, and that we needed to convince CDC to take on end-of-life issues. Now, since then, we have done, we've continued to be in conversation with many of these leaders, and we have some data. We know that actually more than 80% of those who are directly involved in community-state partnerships continue to work in end-of-life care in some way. They found another home to do their work. There are statewide coalitions. They have transformed themselves pretty significantly, but if you just look at the web, about 3/4 of the states report activity at a state level. We also know that there have been some changes. The work has evolved over time. Certainly, it is true that we see end-of-life care, palliative care institutionalized now. People know how to pronounce the word. POLST has spread like wildfire. It's really quite amazing to me. We heard from Lynn this morning about the needs of family caregivers, and there's much, much more concern and attention being given to that. And also that I think many people are coming to the place that advanced care planning needs to be redefined, that we need to shift our locus of concern away from these legal transactional models toward shared decision-making. So I want to assure you that as you, members of the committee, make your recommendations, that there is a willing workforce. There are foot soldiers who will carry your recommendations forward and who will, I believe some of these people would march into hell to make this better. So I'm going to be bold enough now to make I'm going to recommend 5 things that I hope you might consider recommending. I think that palliative care should be established as the standard of care for those with advanced chronic illnesses and those who are terminally ill, and that we need to work very hard to see that this happens across settings, no matter where they are. We've got to get palliative care really into nursing homes. We've really got to get palliative care into community. Hospital-based palliative care is critically important. We're doing pretty well there. We've got to keep pushing it forward. We must expand the workforce. There's no question about that, and there are a number of things in the outline that I suggest for your consideration. Here's probably the heart of what I think needs to happen. And Phil, this will sound a little familiar to you. We need to initiate a public health campaign to improve end-of-life care. I think we have to get the Surgeon General involved in educating the American public that more is not always better, that palliative care provides significant benefits, including longer life in most instances, that naming a surrogate or an agent is important to those of us who will be without capacity at the end of life, and it's very important to our families, and that we need to give very special attention to those who've been traditionally marginalized and who hold disparate views from the dominant culture. I do think the faith community is an important partner, but I think those terms have to be defined very carefully. And for God's sake, the CDC has got to get involved in this. It just blows my mind that the little project they had at the Center of Aging Studies with the transition to new leadership was discontinued. So I also think that we need to overhaul Medicare and Medicaid policy, and reimbursement needs to focus on needs rather than prognosis or location of setting. And again, we need to give special attention to certain populations. We mentioned this morning those who live beyond their family. The American Bar Association Commission on Law and Aging did a marvelous project around the unbefriended. I was privileged to be on the commission at that time. I don't like that term very much, but I think it's very descriptive and attention-getting. So let me conclude here. Many of you know that a little more than 2 years ago, I was diagnosed with a terminal cancer. I have been in remission and have worked hard at staying in remission. But as I contemplate my future, I feel really confident because of the work of those I've referred to and the work of many of you in this room, that I will have a good experience and my family, it won't be so hard for them. But there is work that must be done for us to get there. So this has shifted in my thinking from being about them to being about me. And I want you to get my needs addressed and do it properly. Thank you.
Well, hello. It's nice to be here. I'm Peg Metzger, and I think I was invited to represent Massachusetts because I am the former executive director of the former Massachusetts Commission on End-of-Life Care. One of my current hats is to be the legal advisor to the Mass MOLST program, which is based on the POLST program. So I'm happy to be here to report on what's happening in Massachusetts, but I'm also really happy that coming here gave me an opportunity to circle around and touch base around the state to make sure I knew what was going on. So that alone was very worthwhile. End of life in Massachusetts is a story with ups and downs. It's a story, there's no straight lines in this work, it seems. A lot of disappointments, a lot of setbacks, but then always followed by renewed efforts and renewed activities. And certainly a story that has a lot of circling in place, so that this would be evidenced by the fact that many times the problem statements and then the recommendations often have a familiar ring over periods of years. But I reference these early efforts because I think they're really important. Because I think at every stage we've created certain building blocks that have allowed us to build towards the future progress, the current work. And that it seems to me that nothing happens overnight, or frankly, nothing happens in a day, a week, a month, but things are happening. And I just would want to acknowledge from the start, this echoes something that Myra said, that at every stage this work has been involve really dedicated people in the trenches and actually some very important champions and advocates at very high levels within the state. So it is reinforcing, in fact. So I do want to report on the current progress today, but before I get to those particulars, I need to highlight, and this I think is something that may be counterintuitive to some, because of so much fear involved with healthcare reform. But it seems to me that the current progress in end-of-life care in Massachusetts, both the programs and the policies, are developing in the context of, and frankly, actually are being swept along by the momentum of healthcare reform. And the enormous transformation and change within the overall healthcare delivery system that's happening, and financing systems that are happening in Massachusetts. So for us, these transformations stem back to the 2006 landmark Massachusetts healthcare reform. The landmark is part of the title, even that's unofficial, but it's never been referred to without landmark. So before the Patient Protection and Affordable Care Act. But before I even go further with this, let me just set the stage a little bit with what we call the unique Massachusetts medical legal culture. So we are the state with the highest rate of health insurance coverage. That was actually and entirely the goal of that the focus of that 2006 legislation, access to health insurance coverage. And that legislation emerged when a very, very diverse coalition of interests came together to tackle the problem of the uninsured. We have a tradition of plugging away at tough issues in Massachusetts. So we are also the state with the highest per capita healthcare spending. And as you would expect, I don't have the pictures to show you from the Dartmouth Atlas. I would just refer you to those. But the costs for the on the whole variety of end-of-life measures are equally high. So you can get your data on that. But having tackled access, and that really was the focus in 2006, costs can no longer be ignored, and there are fundamental efforts that have been underway, really spurred by payment reform legislation that followed the 2006 Massachusetts legislation. We have 2008 legislation, 2010 legislation, and 2012 legislation that really are addressing cost issues and are remaking the delivery and payment systems. So that's important, and I will get back to that. We have an abundance, with our abundance of academic medical centers, and we have more physicians and more specialists per capita than any other state, we're a medical culture that focuses on individuals and individual treatment plans, and that's a theme. I think the expert panel report was in your reading. That's a theme I hope you picked up in that report. We're actually rich, we have a rich diversity of languages and cultures represented among the foreign-born in Massachusetts. So our work on the MOLST form, for example, and the companion materials, all of that is available right now in Spanish, Portuguese, Vietnamese, and Chinese, although just the simplified Mandarin. I expect that the next languages that we will be adding are likely to be Russian and Haitian Creole. We have a big focus on the patient-centered medical home model, and the Massachusetts Executive Office of Health and Human Services has set a goal of having all primary care practices in Massachusetts be patient-centered medical homes by 2015. And actually, I understand there's much progress on that measure. Turning to some of the legal issues on which we are also a little bit unique, right? You're never a little unique. We are different. State law does authorize completion of a healthcare proxy to appoint a healthcare agent when patients lack capacity to make or communicate their healthcare differences. This is particularly important. We are like other states in that respect, but this is particularly important in Massachusetts because, unlike most other states, we do not have any state law authorizing living wills. They can serve as evidence of patient preferences if they're presented, but it's not what folks are generally looking for. By folks, I mean the clinicians are generally looking for. Further, Massachusetts has no state law establishing a hierarchy of default surrogates, and this makes the signing of a healthcare proxy to appoint a healthcare agent particularly important because there are barriers to use of or to reliance on default surrogates, particularly outside of hospitals in Massachusetts. So that is really, we're putting a very high emphasis on the need to get a proxy appointed. Further, we have actually a long history of out-of-hospital DNR recognition. We've had this out-of-hospital since 1999, was the creation of by the Department of Public Health, Office of Emergency Medical Services, an out-of-hospital DNR protocol. It was a verification protocol. It was limited to use by emergency personnel, only in outpatient settings, and it only addressed resuscitation. So it was very limited in its use, and even though it was, even with this limited scope, it was pretty widely recognized as underutilized. On the other hand, it was something that emergency responders understood and had been trained on. And so we've had this experience over a long period of time, and the Office of Emergency Medical Services folks did revise their protocol for the 2012 expansion of our MOLST program. So with that, I think I want to go back to the momentum that we built on with healthcare reform and the extent to which it's brought issues related to end-of-life care to the fore. So back in 2006, when we passed our landmark legislation, it did include a couple of issues that were important for end-of-life care. First, it included a pediatric palliative care network, and this was really outstanding work. It was the result of years and years of agitation and advocacy, primarily by the Massachusetts Hospice and Palliative Care Federation. That actually continues to be funded to this day and was a real triumph. But it also, this 2006 legislation, created a Healthcare Quality and Cost Council. And that council, with the benefit of some really outstanding leadership, recognized end-of-life care as an important area for quality improvement that could also possibly result in lower costs. And so that council created an end-of-life and chronic care committee. And I'm going to trace everything right back to the work of that council and that committee, because with input from that council, the next round of legislation, the 2008 amendments to the healthcare reform legislation, actually included 3 end-of-life, specifically end-of-life provisions. Section 41, which mandated the creation of an expert panel on end-of-life care to recommend public policy and best practices. Now, I say mandated. It didn't fund, and so keep in mind that it hasn't happened, but it was, clearly explicated. Section 42 was the initiation of a public awareness campaign to highlight the importance of end-of-life care planning. And then Section 43, which was the initiation of a pilot program for communicating medical orders for life-sustaining treatment, what we call MOLST, across at least one region of Massachusetts. This is where I just need to stop and give a disclaimer, because I want to say health reform in Massachusetts and across the country is massive. The implications are profound. What I'm describing is this tiny little narrow focused lens through end-of-life care. So let's just turn to the activity in response to 2008, because I'm running late. So since in response to the 2008 legislation, we have the MOLST demonstration project completed and report with expansion recommendations. And we had an expert panel that came together, convened in 2009 under the leadership of Dr. Lachlan Farrow and James Conway. They met over a period of months. They created a report that was released, delayed because we can never forget political sensitivities during election years, but it was released. The recommendations included a public awareness campaign, of course, harkens back to the 2008 legislation, and it recommended MOLST expansion across Massachusetts. This was enormously reinforcing because it coincided with the release of the Massachusetts report, the MOLST report, which also was recommending expansion, and synergy, as we know, is a good thing. So we have 6 areas of recommendations for from the panel, and while you all know that we haven't accomplished all these goals, that would be a real misunderstanding. We haven't even approached many of these goals. But the good news is that there is activity under each of these goals. And so what I would say is that with respect to informing and empowering residents, we have MOLST expansion, and MOLST expansion at this point is well underway and projected to be statewide by the end of 2014. More importantly, we are back to this issue of a campaign. And what I want to say is, while the Commonwealth has not launched a public campaign, the fact is that the national endeavor that Ellen Goodman and Institute for Healthcare Improvement has founded, the Conversation Project, lives in Massachusetts. It's housed in Massachusetts, and we are benefiting enormously by that. They have effectively become our public campaign, even though it's not state-supported and it's not state-funded or endorsed, but they bring a whole lot to the table, and we are grateful for their work and their willingness to collaborate with us in all the efforts in the field. The acts of 2012 go to this issue of high-quality patient-centered care because of the focus on the patient-centered medical homes that's embedded in the 2012. And there were many instances in which small references to end-of-life care, so end-of-life care as palliative care as part of care teams, palliative care or as part of transitions, all of this is becoming important. We actually have had a change from the Board of Registration in Medicine that's now requiring 2 hours of end-of-life continuing education credits for licensure in Massachusetts, effective January 1st, 2012, which goes to the issue of the workforce. The then executive director of the Board of Registration sat on the expert panel. So that was a good, again, a good synergy. The ACOs that are emerging from payment reform are really important components of the changes with respect to financing. In addition, the legislature has passed expansions to the Mass Health Basic and the Mass Health Standard. That's our Medicaid program, so that hospice is included for more of that population. And again, I want to say that the activity in Massachusetts, both because we have 5 of the 32 pioneer ACOs in our state, and because so many of our medical centers are being supported by CMS innovation grants, that there is private sector initiatives really aimed at assuring concurrent care so that life-prolonging measures can be received together with palliative care and thereby enhance the quality of life. There's a lot of anxiety about all of where this is all going to go, and it's very hard to speak definitively or predict, but I would say that it is creating momentum. I think that the area where we probably have the biggest challenge is the creation of an entity to sort of coordinate and oversee the whole issue of end-of-life care. This is one where I would say no one has volunteered to pick up the ball, and leave us pondering, where should we put it, what should we do, what's the sustainable funding stream. It is being discussed. I think there are some proposals kicking around. The jury is out. I think actually that much depends on this, and it may be the most important for long-term sustainability. And finally, we did, in the 2012 legislation, also have a requirement that the DPH, Department of Public Health, develop regulations requiring hospitals, SNFs, and clinics provide information about palliative care and end-of-life care options to appropriate patients. And those regulations are currently in development. They won't be finalized before the end of the year, but I am told that they are very likely to come out shortly thereafter. So I don't have time really to do much with MOLST. I just want to very quickly show you that we had a lengthy process starting with the 2008 legislation. We've been through a demonstration. We've trained all the emergency medical personnel. We've enlisted champions and trained the trainers, and we're on a path towards statewide usage by the end of 2014. It is a collaborative effort. It's the Mass Executive Office of Health and Human Services, the Department of Public Health, Executive Office of Elder Affairs, and Center for Health Policy and Research at Commonwealth Medicine. We've had lots of good endorsements, and so I'm proud of those. And I would just highlight really the extent to which we've tried to incorporate very carefully the input from the community, clinicians, and public. This is our MOLST report card, which I can explain in questions if you have any. And I guess if I had to, there are legal issues that relate to impediment that I can see I need to skip over. I will just end by saying that for our transformation summary, it really has required the innovation of all the players in the system, and I think that's what it's going to take. Thank you.
We do have time now for some questions from the committee members. Please raise your hand if you have it, and we'll get a microphone.
Thanks. Bernard Lowe from the Greenwall Foundation. First, I want to really thank the panel, not just for their lucid presentations, but really for the pioneering work you all three have done to sort of improve the care of of patients and the public. I have questions, actually have to do with some of the legal uncertainties and perhaps barriers. And I was wondering if you could say a little bit more about things that were just alluded to, Naomi, in the report you did with Charlie Sabatino regarding some limitations legally. So first, are POLST orders really binding? And I guess my concern is what happens if a physician has a conscientious personal objection, to example, against withholding tube feedings, artificial fluids and nutrition, or the institution has a policy against that? What happens to the POLST orders? Are they overridden on admission to the emergency department? The second question really has to do with surrogates authorizing or writing the POLST orders with the physician. May surrogates be self-identified if not designated by the patient? Are there problems that come up where there are questions raised by either another family member or someone in the hospital about whether the surrogate whose name is on the form is actually appropriate to be the surrogate?
Well, thank you, Bernie. And what you're suggesting is, what are the pathways, what are the barriers, what are the problems, and they vary by state. And Charlie Sabatino has carefully cataloged, and on the POLST.org website, there are descriptions of every state. What are the barriers related to their out-of-hospital do not resuscitate law, their surrogate law, their advanced directives law? What barriers do they face relative to a POLST program specifically? And they are individual at a state level. Some states have specific barriers that are problematic and have caused the program to need to deal with those legal issues before they could actually do statewide implementation. Certainly this is a state-based program, just as advanced directives and surrogacy laws are state-based. And there are significant challenges in some states and an easier time in others. The POLST program at times follows a pathway of legislation, as it has in California, West Virginia, several states, and at other times has been able to be done just through regulation and a grassroots effort, as it has in Oregon. So there are real differences, and part of it is the substrate of what you start with. If people have specific questions about individual states and they're not clear on the website, Amy Vandenbroek can help you connect with Charlie Sabatino or the individual resources.
I think my issue is really a bigger picture issue. So if I sign one of these, depending on what state I'm in, I either can be assured or may not be assured that very specific preferences I have will actually be honored when I'm not able to sort of advocate for the decisions I wanted.
And how well you're respected in the individual states depends on some of that legislation. But I could discuss Oregon, which I know a lot more about. And every hospital and health system and long-term care facility are utilizing the form for some of their residents. That does not mean that there is no policy in a facility to say you can't use it. We don't have that as an institutional objection. But we do have individuals who would have concerns about withholding and withdrawing life-sustaining treatment. And how does that play out at the institutional level if an individual is unwilling? Well, the medical board for Oregon wrote a document that says until or unless you have information to the contrary, you should follow what's written on the POLST form. Now, that may mean that care is transferred to a different healthcare professional who's willing. What we find is that we have such a high level of respect when we have this degree of penetration that there is actually outrage by the healthcare professionals, as well as patients and families, if orders are not found or they're ignored. but it takes a long time, and you have to have only a few cases happening to have it become an M&M and people are outraged. It takes a long time to get to that level. But once you're there, the culture really anticipates that you're going to find a way to honor the patient's wishes and that the patient does have a right to have them respected. Yes, a substantial percentage of POLST forms are completed with surrogates. We'll know a lot more about that when we do the next analysis of the POLST registry. But each state then falls back on its surrogate laws, and who can be a surrogate goes back to Charlie Sabatino's, what do the state laws say about surrogates?
And I would just add that in Massachusetts, a self-identified surrogate cannot sign a MOLST form. So
That
it
would be
needs to
true in
be an
Oregon, too.
it needs to be an appointed surrogate.
And some states have default surrogate laws. So again, it's very different by state. That would be very state-specific question, Bernie.
Well, clearly we have two very unique states here. I started out part of my career in Massachusetts. I think I'm going to end the rest of it in Oregon. I have a question for each of you, though. I'd like to hear a little bit more about which workforce you're thinking about in Massachusetts. What kind of people and what would they be doing? And then for Dr. Toll, I wonder, even though it only represents 2 out of 1,000, I wonder if you could share a little bit more about what happens with the experience regarding physician-assisted suicide. I think that's a topic that is relatively unique to Oregon, Washington, and I think we'd benefit from hearing more about that.
Okay. You go first.
Well, I would just say on the workforce, we have a broad view of what needs to happen across all levels, including physician, nurse practitioner. It's being physician assistant. It's being built into the care teams in patient-centered medical homes and across accountable care organizations, which are really the financing piece of it. But it also it goes well beyond that also to include the whole workforce. So when I talk about a board of registration requirement of 2 hours of end-of-life certification, that's just a small.
It's not a workforce more unique to the end-of-life care. It's just a general workforce.
Well, I think I think improving the overall skill level was the focus of the expert panel, but increasing the numbers of people trained in geriatrics, palliative care, all of that is also very important.
Well, to respond to her question first, I deeply believe a rising tide lifts all boats. And we spend a lot of time doing what we can to reach everyone a little bit with some degree of advanced care planning, familiarity with POLST, and tying the whole process together. We rarely teach about POLST alone and would teach it as an integrated activity in the context of all of the broader care at the end of life. Oregon, I'm not sure what all you want. There's certainly much could be said about the challenges Oregon faced. Our Center for, I think it's fair to sort of declare one's political position first for anyone to have any context. The Center for Ethics in Healthcare at the Oregon Health Sciences University, which I direct and have directed since 1989, so long prior to the Oregon vote, did not ever take a stand on death with dignity. We have faculty who do research. We have faculty who funded the Physicians for Compassionate Care against the Death with Dignity Act. We have donors for and against, and they're almost evenly divided. And so we have not taken a stand, whether it's a good thing or a bad thing, for our state or for any other state to undertake. So that's kind of where I'm starting this. And the language one chooses to describe the activity actually in my state and in some other areas declares your political stand. If you use the term physician-assisted suicide, it means you're opposed. If you use death with dignity, it means you're in support. So when I introduced myself, I used both. And so that's the complex environment. Now, certainly in an environment with that much spotlight on end-of-life care, it does present opportunities to really push for palliative care teams, to really push for the alternatives in a way that we chose as an ethics center to put an enormous amount of energy. To look at people and say, what do you want to be known for? And they fund a palliative care team. And so those were the forces and the way that we have played things out. Now, that does not mean I've entirely ignored this. With the state, we've analyzed who doesn't choose the law and looked at the demographics of those who are not participating. It's not random. The people who participate in the Oregon Death with Dignity Act, one of the biggest factors suggesting an increased likelihood, 8-fold ratio, is that you have an advanced degree beyond a bachelor's. The number of people who are other than white who have used the law are very small. In 15 years, one African American has. So it is the insured, the somewhat younger than average age of death, the empowered and educated on average, and typically have cancer, are white, and live on the western side of our mountains. If you understood Oregon politics, that would make more sense to you. But Eastern Oregon is, in many ways, politically more conservative, and almost none of the death with dignity takes place on the eastern side of the mountains.
That's very helpful. I know that in Massachusetts, this was on the ballot.
It's a ballot
recently,
initiative.
And Marcia Angel, bless her heart, wrote a very interesting piece about it in the New York Review of Books, pleading for it, but yet it didn't pass.
It was 49 to 51%, so it was close. But it did not pass.
Oregon only passed by 32,000 votes the first time. The margin was razor thin the first time. We voted 3 years later, again, by the legislature, and then the margin was large.
Do any more committee members have a question? I've got one if they don't. Okay. With regard to the landmark Massachusetts legislation, obviously it was before the Affordable Care Act. The Affordable Care Act is now the law of the land, is going to be implemented. And I guess I would be interested in, since Massachusetts came first in many regards, and there are similarities, although some differences, what impact did that have on demand? What impact did that have on availability of adequate healthcare professionals to be able to meet that demand? What did it do with cost? And how are you coping with it as it relates to what we're going to have to deal with on end-of-life issues?
Right, and I think it may be hard to generalize from Massachusetts to the United States on all of those issues, but I guess what I would say is we went to virtually universal insurance. I think our cost has always been a problem. I don't think people see the cost as the cost problem as having been driven by that. It's that we now need to address cost.
Who had a question? Carla, did you have?
Just a quick question to ask. How are these POLST orders transferred electronically? How do they relate to EMRs? I might have missed it, I'm sorry.
Yes. First of all, they are scanned and loaded into the EPIC system because we're going to be bilingual, meaning paper and electronic, for at least a decade. And the reason is these are in private homes for people in home hospice. They're in adult foster cares. They're in places that are not going to be electronic for a very long time. And so we're going to need both the paper form and then the ability to load it electronically, print it, send it electronically to the registry, and at the same time have a paper copy in a private home. Mm-hmm.
All right, I want to, on behalf of the committee, thank you all very much for a very informative session. We appreciate it.